Acute kidney injury and chronic kidney disease, Chapter 60. Acute kidney injury is defined as the rapid reduction in kidney function resulting in a failure to maintain waste elimination, fluid and electrolyte balance, and acid-base balance. It can be pre-renal, which is a decreased blood flow to the kidneys, usually from blood loss, dehydration, infection, burns, or MI. It can be intrarenal, which is damage that has occurred to the functional part of the kidney. It can be caused by nephrotoxic agents or medications, contrast dyes, connective tissue disorders such as lupus, cholesterol deposits that obstruct blood flow to the kidney. Or postrenal, which involves the urinary system below the kidney that prevents the urine from draining, such as compression or obstruction of the urinary tract from an enlarged prostate, from masses, from clots or calculi, or a neurogenic bladder. Box 60.2 does show you diseases and conditions that contribute to acute kidney injury. It's on page 1457 in your book. And then box 60.3 on page 1458 shows you examples of potentially nephrotoxic substances, such as different antibiotics or antimicrobials like your sulfonamides and vancomycin, your aminoglycoside antibiotics like gentamicin, neomycin, chemotherapy agents like cisplatin and methotrexate, NSAIDs, your ketorolac, naproxen, celecoxib. Other drugs include acetaminophen, cyclosporin, metformin, and then your other substances are carbon tetrachloride, which was formerly used as a dry cleaning solvent and used in fire extinguishers and refrigerant. It has been largely phased out, but you may still find it in some industrial settings. And ethylene glycol, which is found in antifreeze and de-icing solutions. Some non-drug chemical agents include your radiographic contrast media, pesticides, fungicides, myoglobin, which is from your breakdown of skeletal muscle. Some heavy metals and ions that could be potentially nephrotoxic is bismuth, lead, copper sulfate, gold salts, mercuric chloride, and arsenic. So risk factors in your hospitalized patients, risk factors for developing acute kidney injury include shock, cardiac surgery, hypotension, prolonged mechanical ventilation, and sepsis. And then also in the older adult that has diabetes, hypertension, peripheral vascular disease, liver disease, or chronic kidney disease increases their risk of developing acute kidney injury. 20% of all hospitalized patients and 60% of ICU patients develop acute kidney injury. For your assessment findings, you're going to see oliguria, which is defined as less than 400 milliliters per day. Your additional symptoms will be due to that buildup of nitrogenous waste, azotemia, and your declining urine output. So less than 0.5 milliliters per kilogram per hour for 2 or more hours. As your acute kidney injury progresses, you'll start showing signs of fluid overload. Those symptoms, remember, are pulmonary crackles, dependent and generalized edema, decreased oxygenation, some confusion, increased respiratory rate and dyspnea. Hypoperfusion signs, you want to monitor your vital signs for early recognition for symptoms of reduced blood volume, such as your mean arterial pressure below 65 milligrams of mercury, some tachycardia, 30 peripheral pulses or decrease in cognition, and your hypoxemic or ischemic signs that will show damage is your SpO2 below 88%. Complications from acute injury, this can be found in box 60.1 on page 1456 in your book. They affect many systems. Metabolic complications will include metabolic acidosis, hyperlipidemia, hyperkalemia, hyponatremia, hypocalcemia, hypophosphatemia. So go back and review all of your electrolyte imbalances. Cardiopulmonary complications include peripheral and pulmonary edema, heart failure, pulmonary embolism, pericarditis, pericardial effusion, hypertension, myocardial infarction. Your neurologic complications are neuromuscular irritability or weakness, hysterexis, seizures, mental status changes. Your immune infectious complications are pneumonia and sepsis. GI complications are nausea, vomiting, decreased peristalsis, enteral nutrition intolerance, malnutrition, ulcer formation, and bleeding. Hematologic complications include bleeding, thrombosis, anemia. Renal complications are chronic kidney disease and your end-stage kidney disease. End-stage kidney disease you may also hear it referred to as end-stage renal disease. Other complications can include hiccups, an elevated parathyroid hormone, or a low thyroid hormone level. Trends and findings from your tests and labs, Chapter 57 on page 1392. You want to look at that table 57.3, your laboratory profile. These are your kidney function blood studies. Normal range for serum creatinine in males is 0.6 to 1.2, and for females is 0.5 to 1.1. Males are slightly higher due to the slightly increased muscle mass, or your athletes might have a slightly increased muscle mass, so their serum creatinine may be also slightly higher. An increased level could indicate kidney impairment, and a decreased level may be caused by decreased muscle mass. Your blood urea nitrogen, so BUN, normal range is 10 to 20. It might be slightly higher in your older adult. Your increased level may indicate liver or kidney disease, dehydration, or decreased kidney perfusion. Could be due to a high protein diet, infection, stress, steroid use, GI bleeding, or other situations in which the blood is in body tissues. And a decreased level may indicate malnutrition, fluid volume excess, or severe hepatic damage. Your BUN creatinine ratio, normal range is 6 to 25. 15.5 is your optimal level for adults. An increased ratio may indicate fluid volume deficit, obstructive uropathy, catabolic state, or a high protein diet. And a decreased ratio may indicate fluid volume excess. Serum creatinine is a good indicator of kidney function because there's no pathologic condition other than kidney disease that will increase your serum creatinine level. The BUN level is not always elevated with kidney disease, so it's not the best indicator of kidney function. In dehydration, like we said, the BUN is elevated and creatinine is normal. So other labs that would help us assess for dehydration would be like our CBC. You'll have an increase in your H&H and RBCs. Urinalysis, you'll have an increased specific gravity, which your normal range is 1.005 to 1.030. Remember that specific gravity range for your urinalysis. And then your BUN and creatinine elevated together does suggest kidney dysfunction. So if you have an elevated BUN and you also have an elevated creatinine, it is suggestive of kidney dysfunction. So your trends and findings, refer to table 60.3. For kidney disease, your serum sodium could be normal, increased, or decreased. Remember, your normal range is 136 to 135 or 135 to 145. Your serum potassium normal range is 3.5 to 5. In kidney disease, it is increased. Serum phosphate or phosphorus is 3 to 4.5. Older adults, it might be slightly decreased, but in kidney disease, it would be increased. Serum calcium would be decreased. Remember, your calcium and phosphorus have an inverse relationship. So if your phosphate is increased, then your calcium will be decreased. Your creatinine level, we already talked about, would be elevated, and that is the best indicator for kidney function. Acid-base imbalance can occur with acute kidney injury, would be your metabolic acidosis. So you'll have a decreased pH, decreased HCO3, all of your values actually would be decreased. And then what are your concerns with having that elevated potassium or that increase in elevated potassium? You would want to watch for cardiac issues, so monitoring for any dysrhythmias, monitor blood pressure, heart rate. And if we notice any, we would want to, of course, notify our provider immediately and assess the patient, of course, for any symptoms of hyperkalemia. Diagnostics that can be done for acute kidney injury is a kidney biopsy. This information can be found in chapter 57, starting on page 1401 in your book. So to begin with, make sure your patient for preparation. Before the kidney biopsy, you would of course want to provide any education about the procedure, obtain an informed consent. Lab assessment is going to look for any increased risk of bleeding and coagulation diseases. So usually a PT, APTT, platelet count, bleeding time. The patient will need to be NPO for 4 to 6 hours prior to the procedure. And we want to have strict blood pressure control. And then correct any anemia with any blood transfusions. And if they have excessive waste buildup, they may need dialysis. After the kidney biopsy, you would want to follow up. Follow-up is that there's a significant risk for bleeding. So for 24 hours after the biopsy, you want to monitor the dressing site, vital signs, urine output, their H&H. Look for any hematuria. That the hematuria should resolve on its own. But if it gets worse or doesn't seem to be resolving, we need to notify the provider. An internal bleed is not readily visible, but it's suspected if the patient complains of flank pain, if they start having a decreased blood pressure, decrease in their urinary output. With severe bleeding, some patients develop bruising along the flank and back, accompanied by pain. And then the patient may have some local pain after the biopsy. It begins to radiate to the flank, back, and around the front of the abdomen. And bleeding may have started or hematoma may be forming. So what would you expect your vital sign to demonstrate with any bleeding? So what do you do if you notice any bleeding? Of course, I would want to call the physician or the rapid response team with any significant changes or concerning changes in their patient's vital signs. The patient will be on strict bed rest after the procedure for 2 to 6 hours. They can elevate their head to bed and usually resume their normal diet. Bathroom privileges will be limited after the bed rest is up if they have no evidence of bleeding. After 24 hours, they may resume their general activities. Encourage them to avoid any heavy lifting, exercising, or performing other strenuous activities for at least 1 to 2 weeks after the biopsy. And their driving may also be restricted, usually based on if they're requiring any medications for pain. So treatment for acute renal failure is determined by what caused the renal failure. For pre-renal acute renal failure, you would want to do a fluid challenge. This is going to promote kidney perfusion in those who are not fluid overloaded. Usually about 1/2 to 1 liter normal saline bolus over an hour, and you're going to watch and monitor for any signs of fluid overload. For your nephrotoxic medications, you would of course want to eliminate those. And once again, you can find those listed in box 60.3. And then you want to treat clinical manifestations. So you want to treat hyperkalemia. Loop diuretics such as furosemide is used to increase the excretion of water and electrolytes. This is contraindicated if the kidneys are not producing urine. And then remember your CBK drops. So calcium gluconate, bicarb, insulin, and glucose, and then K-exalate or some type of potassium binder, and then D for your diuretics or dialysis. So that's how you would want to treat those hyperkalemia. For management and prevention, you would want to restrict or limit the intake of foods that contain potassium. So your registered dietitian nutritionist can assist with establishing a diet for your patient's caloric and protein needs and for any restrictions they may have. They may need nutritional supplementation if they have poor intake due to any GI symptoms. Once again, your dietitian can help assist with that. They'll need to follow up with a healthcare team that may include a nephrologist, and then follow up labs for reassessment of renal function. And we want to assess their level of independence and social family support. They may need home health nursing or social work support for supplies. So for chronic kidney disease now, chronic kidney disease, complete recovery is not possible due to the permanent damage sustained by the kidney. Kidney damage sustained through chronic nephropathies and gradually progress to fibrosis and destruction of the normal structure of the kidney that affects all three compartments: the glomeruli, tubules, and the vessels. Chronic kidney disease, over time gradually you get loss of kidney function, and that leads to end-stage kidney failure. Risk factors for CKD, a lot of diseases that cause CKD and progresses to end-stage renal disease. The most common are diabetes mellitus and hypertension. There are some modifiable risk factors such as hypertension, proteinuria, which is linked to your dietary intake of protein, metabolic factors such as your insulin resistance, obesity, and smoking. Your non-modifiable risk factors are your race and ethnicity. Asian, Hispanic, and Black clients are at high risk, and also your males greater than 65. Your assessment findings, remember these assessment findings are expected, so there's no need for immediate alarm unless they are having a compromising of their ABCs and safety. Most assessments, patients with CKD are asymptomatic, and they're initially diagnosed through lab studies. So by that time, it's diagnosed in lab studies, permanent damage to approximately 80 to 90% of the kidney function has developed. You'll have alterations in fluids, electrolytes, acid-base balance, and waste products. And the client, of course, will present with those manifestations of fluid overload, edema, crackles in lungs as they gallop, and jugular vein distension. Some lethargy and seizures, which can be indicative of your neurological changes due to toxin buildup. Potassium-induced dysrhythmias, metabolic acidosis like tachypnea and hypernypnia with advancement to Kussmaul respirations that can occur to compensate. Your signs and symptoms of anemia and abnormal bleeding, such as that's due from your decreased erythropoietin, leading to decreased red blood cell production, decreased red blood cell lifespan due to uremia and metabolic acidosis. So you'll have that fatigue, pallor, weakness, dyspnea, dizziness, bruising, petechiae, mucosal bleeding, melena. Your GI symptoms include foul breath and skin changes. They'll have pruritus, and a uremic frost will develop. That's a layer of urea crystals from their evaporated sweat will be on their skin. GU symptoms, urine output varies with your remaining kidney function. Oliguria may be present in end-stage kidney disease, indicating that return to normal kidney function is unlikely. Your stages of chronic kidney disease can be found on page 1465 in table 60.4. Stage 1 means they have an GFR greater than 90. The kidneys are functioning within normal range and there's little kidney damage present. Stage 2 is 60 to 89. Kidneys are still functioning within normal range and you may have mild kidney damage. Stage 3A is 45 to 59. So kidneys are not functioning within normal range. You have mild to moderate damage to the kidneys. Stage 3B is 30 to 44. Moderate to severe damage to the kidneys is present. Kidneys are not functioning normally. Stage 4, 15 to 29. They're not functioning within normal range and they're at risk of not functioning at all, and you have severe kidney damage evident. And then of course stage 5 is less than 15. Your kidneys very close to not functioning or they have already stopped functioning, and you have severe and significant kidney damage is present, which is your kidney failure. For CKD, your urinalysis may show protein, glucose, and RBCs, and your ABG findings are going to be the metabolic acidosis. Complications. Progressive disease is without recovery, kidney function. Your electrolyte imbalances can cause dysrhythmias, fluid overload, hypertension, metabolic acidosis, infection, and uremia. And we will talk more about complications related specifically to hemodialysis and peritoneal dialysis in later slides. There are three main goals for your nursing interventions and treatments. The first one is kidney disease prevention or slowing of the kidney disease progression. If you'll refer to box 60.6 in your book, page 1468, look at the patient and family education. So you would want to be sure you're educating the patient and the family to look at their urine, note any changes in the urine color, clarity, or odor. Monitor how frequently they go. More frequent or infrequent voiding, not associated with any changes in fluid intake, can signal health problems. If they're having any discomfort or distress with passage of urine, this is not normal. They need to report their symptoms to their primary care provider. Encourage them to drink 1 to 2 liters of fluid a day. Water is ideal for flushing out any body waste. Avoid sugary, high-calorie drinks. This can lead to weight gain and sugar-induced urination, and it's due to those low-quality calories that you get from sugary, high-calorie drinks. Periodic measurement of kidney function by your primary care physician. Getting a serum creatinine and urinalysis should be done. And if they do have any history of hypertension, diabetes, or kidney disease, or if they have a family history of kidney disease, they should know their serum creatinine level and GFR, and then get it checked up at least once a year. If they do have a decreased kidney function present, they need to check with their primary doctor. If there's any risk to kidney functions from any prescription medications, diagnostic test, or therapeutic procedure, check with their doctor before taking any over-the-counter medications or any non-prescription drugs. They can check with their pharmacist as well. And then evaluate contribution of diet to risk for kidney disease. So is it something they're eating that puts them at greater risk for kidney disease? Increased physical as well as psychosocial well-being with the nurse. Empowering the client to take charge of their disease and well-being is the second intervention. So anxiety, depression, mental distress can alter the quality of life for clients who have CKD, especially once this progresses into end-stage renal disease. Hemodialysis treatment results in food, fluid, and time restrictions, such as the hours spent at the dialysis center related to treatments, and that can add to the decline of quality of life. Third, you would want to continue monitoring disease progression and the treatment of complications, such as hypervolemia. So what is your best indicator of fluid balance? That would be your daily weight and your intake and output. So you would want to teach the patient to weigh themselves, or we would want to be sure we're also weighing the patient daily at the same time each day, using the same scales, with the same amount of clothing on, and then graphing those results. Observe those weight graph trends. We're looking for 1 liter, we're looking for any weight gain of greater than 1 kilogram. 1 liter of fluid equals 1 kilogram, or 2.2 pounds. We also want to accurately measure all fluid intake and output. Teach the patient about their need to keep their fluid intake within the prescribed restricted amounts, and that they evenly distribute those throughout that 24-hour period. So knowing when their 24 hours start, when their 24-hour ends. Usually they don't have as much assigned at night when they're sleeping, so that they have the most split through the day. They still want some at night, but not usually as much at night as they would during evening or morning shift. You want to monitor for any signs and symptoms of fluid overload at least every 4 hours. Assess their level of consciousness and degree of cognition, and then ask about any presence of headache or blurred vision. Medications, this can be found on table 60.5. So loop diuretics are going to manage volume overload when urinary elimination is still present. So if they're not voiding, then you would not want to give them a loop diuretic. Epoetin is used to treat anemia. Iron can be used in conjunction with the erythropoietin to produce red blood cells to carry oxygen. And vitamin D can be given to control the balance of calcium, parathyroid hormone, and phosphorus. A phosphorus binder such as sevelamer or Renagel to remove excess phosphorus may be prescribed. A B complex vitamin to replace the vitamin B loss that can be obtained from dialysis. Folic acid can be used to replace folic acid loss with dialysis and to lower homocysteine levels. Vitamin E to treat leg cramps due to fluid and electrolyte shifts in and out of the muscle that occur during dialysis. And topical creams and antihistamine to treat itching and dry skin that's caused by dialysis. So nursing interventions and treatments also does include dialysis. Dialysis does not replace the work a healthy kidney does to maintain various bodily functions. So it's a treatment, but it's not a cure. Dietary restrictions on page 1474, table 60.6, show you the needed restrictions for severe kidney disease, which includes restrictions in protein, fluid, potassium, sodium, and phosphorus, depending on what type of dialysis they are. Kidney transplant. This can be found in your book. Average wait time for a kidney transplant is 4 years. It can greatly improve the quality of life. The recipient's tissue is matched with donor, so the donor can be either a living donor, a non-heart beating donor, or a cadaver. There's in-depth tissue typing, including blood type compatibility done to determine the kidney. And it is surgically implanted into the client. Indications for end-stage renal disease: anuria, proteinuria, severe electrolyte imbalances, significantly elevated BUN and creatinine, and fluid volume overload. All that can be an indication for kidney transplant. Contraindications for kidney transplant would be active cancer, if they have a current infection or a current illness, if they have active alcohol and substance abuse, or non-adherence with their medical regimen. For preoperative care, you want to refer back to Chapter 9 in your book for all of your preoperative, intraoperative, and postoperative care. Postoperatively, though, for a kidney transplant, the priorities are monitoring for infection. So we want to get like a urinary catheter removed 3 to 5 days after surgery due to the increased risk. They're on immunosuppressive therapy, so they're at an increased risk of developing an infection. Remember that immunosuppressive therapy is lifelong, so they should have no skipped or held doses. And immunosuppressive therapy can include medications like corticosteroids, cyclosporin, and monoclonal antibodies. We want to prevent post-transplant rejection. Post-transplant rejection, this table is 60.10 in your book and can be found on page 1490. So there are 3 types of post-transplant rejection. There's hyperacute rejection, acute rejection, and chronic rejection. With your hyperacute rejection, the onset is usually within 48 hours after surgery. Signs to look for are increased temperature and blood pressure, and then pain at that transplant site. Treatment usually includes immediate removal of the transplanted kidney. In acute rejection, the onset's 1 week to any time after surgery, usually occurs over days to weeks, and signs and symptoms include oliguria, anuria, a temperature greater than 100 degrees Fahrenheit or 37.8 degrees Celsius, an increased blood pressure, enlarged or tender kidney, lethargy, elevated serum creatinine, BUN, potassium levels, fluid retention. The treatment for acute rejection includes increasing their dose of immunosuppressive drugs. Chronic rejection occurs gradually during a period of months to years. Signs and symptoms will have a gradual increase in their BUN and serum creatinine levels, some fluid retention, changes in their serum electrolyte levels, fatigue. The treatment for chronic rejection is conservative management until they require dialysis. And then for either dialysis or kidney transplants, we want to evaluate the outcomes. So, for instance, looking at the client, they'll maintain potassium levels within normal limits and have stable BUN and creatinine levels. So what reassessment is needed to determine if that outcome has been achieved? We're going to be drawing some labs, following up. Are any additional interventions needed to determine, depending on what the lab work shows, determines if they need any additional interventions. Another one would be the client will experience improvement or resolution of anemia symptoms with epoetin. So what reassessment is needed to determine if the outcome has been achieved? Once again, we're going to be drawing lab work, and we're going to be checking their RBCs. And what's the adverse effects to monitor for epoetin? Patient teaching, management, and prevention. Remember your patient teaching, health promotion for modifiable risk factors from RNSG 1940, so from MedSurg 1. Lifestyle management, such as smoking cessation, increase in physical activity, altering nutritional choices. They require compassionate education and guidance. They may not be receptive to changing all of those at one time, so letting the patient assist or the client assist as to what they are going to work on first so that you'll have more compliance. Diet, there's meal planning. There's a lot of food restrictions with chronic kidney disease. They need to monitor daily intake of their carbs, protein, sodium, and potassium. Monitor fluid intake also according to any fluid restrictions and teaching them about fluid restrictions. Monitoring their blood pressure and their weight at home. They need to Keep a close watch, and if they notice any significant weight gain, then they need to contact their physician, or any changes in their blood pressure. Let them ask questions and discuss their fears with them. Recognition of the symptoms of possible infection need to be taught to them, and that these symptoms must be reported to their healthcare provider. Teach them some super therapeutic effects of prescribed and over-the-counter meds due to their limited renal excretion. And then, who are the members of this interprofessional healthcare team that the patient will need to follow up with closely? Could even include a nephrologist along with their primary care physician. They could also see a dietitian. They could see a case manager, a social worker. So hemodialysis versus peritoneal dialysis, this can be found in table 60.9 in your book on page 1483. So this will list out advantages, complications, contraindications, access, and procedure for hemodialysis versus peritoneal dialysis. And we will talk about this in more detail. So in hemodialysis, this performs the role of the non-functioning kidney. Once again, hemodialysis is just a treatment. It is not a cure. The client is connected using this access to the hemodialyzer that has a large filter. Access for treatment is through a needle into an access site. The filter of the hemodialyzer has two parts. There's filtering the blood of waste and bath solution called a dialysate that washes the blood. And HD can be formed in the inpatient setting, outpatient dialysis centers, or in the client's home. Indications for hemodialysis include renal insufficiency, acute kidney injury, chronic kidney disease, medication or drug toxicity, persistent hyperkalemia, pulmonary edema, severe hypertension, and hypervolemia. So pre-hemodialysis, as far as nursing care, we would want to assess our AV fistula or graft for thrill and auscultate for a bruit, obtain a daily weight, obtain some vital signs, withhold any medications that will pass through the dialysis membrane, and any antihypertensive medications. Table 60.9 talks about caring for AV fistula or graft. Such as do not take blood pressure readings using that extremity in which the vascular access is placed. And you do not want to perform any venipunctures or start an IV line in that extremity. You want to palpate for thrills and auscultate for buoys over the vascular access site at least every 4 hours while the patient's awake. Assess the patient's distal pulses and circulation in the arm with the access. Elevate the affected extremity after surgery. Encourage routine range of motion exercises. Check for bleeding at the needle insertion sites and assess for any indications of infection at any needle sites. Instruct the patient not to carry heavy objects or anything that compresses the extremity in which the vascular access is placed. And instruct patients not to sleep with their weight on top of the extremity in which the vascular access is placed. If you need a referral of what type of vascular accesses are available for dialysis, you can refer to table 60.7, page 1479 in your book. Intrahemodialysis, we're going to monitor for complications and monitor the client's response, such as checking their blood pressures. We want to prevent hypotension from fluid removal. Additional considerations such as muscle cramps, neurological changes, dialyzer reactions, and hemolysis or air embolism we would want to monitor for. Box 60.11 on page 1482 goes into more detail about caring for a patient undergoing hemodialysis. One thing you do want to be aware of is if the patient had any type of previous event occurring during dialysis treatments, and how well do they tolerate previous dialysis treatments. Of course, keep a check on their vital signs, assessing for any orthostatic hypertension, assess the vascular access site, observe for bleeding, observe for headache, nausea, and vomiting, and assess their serum lab test to evaluate the effectiveness of the treatment. In that critical rescue on page 1482, it says hypertension is common due to the heat transfer from warm solutions can result in vasodilation and cause a drop in blood pressure. So if this happens, usually you reduce the temperature of the dialysate. It can also be due to fluid shifts from plasma volume related to differences in electrolyte concentrations between HD solutions in the blood. So modest declines in blood pressure, you want to adjust the rate of the dialyzer blood flow and place the patient into Trendelenburg position. If the hypotension is sustained or symptomatic, you want to give fluid bolus of 100 to 250 milliliters of normal saline, albumin, or mannitol, whatever's ordered. And they may even need a second bolus. If it's persistent hypertension, it could be indicative of new onset myocardial injury or pericardial disease. So you want to apply to reduce the blood flow, notify the primary care physician urgently, and then dialysis is usually DC'd when the hypertension continues despite 2 bolus infusions. Post-hemodialysis, common problems include hypertension, headache, nausea, vomiting, dizziness, muscle cramps. So continue monitoring the vital signs and report any hypo or hypertension. Compare to pre-dialysis vitals. Your blood pressure and your weight will be reduced as a result of fluid removal. So it's important to obtain a weight to compare to the pre-dialysis weight. Assess the access site for thrill, bruit, signs of infection or bleeding. They may have a slight elevation in temp due to warming of blood during dialysis, but a fever, so a temperature greater than 100.4, may be due to sepsis. You'll want to notify the provider with focused SBAR and recommend to work up like blood culture and sensitivity testing. Avoid non-essential invasive procedures for 4 to 6 hours post-dialysis due to the heparin administered during dialysis to prevent thrombus formation. Potential complications of hemodialysis include dialysis disequilibrium syndrome, which results from too rapid a decrease in BUN and circulating fluid volume that can result in increased intracranial pressure. Anemia, blood loss and remove of folate during dialysis can contribute to worsening anemia that's already present in chronic kidney disease and infectious diseases. Blood transfusions and dialysis access increase the risk of transmission of blood-borne infections. For nursing care for dialysis disequilibrium syndrome, the key is to recognize it early and to notify the provider. So recognize those symptoms: nausea, vomiting, headaches, fatigue, and restlessness. For anemia, we're going to administer erythropoietin to stimulate red blood cell production. So monitor the hemoglobin and RBC level for therapeutic response. Monitor for any signs and symptoms of anemia, including hypotension and tachycardia, and transfuse blood products as prescribed. And then for infectious diseases, we're going to use the sterile technique and skin antisepsis, and then use standard precautions. Client education. The effects of chronic renal disease on a person's health can be significant. Their daily living often includes hours of dialysis and significant changes to diet and lifestyle, which can greatly impact the quality of life. They're more restricted compared to peritoneal dialysis. So what can you do to support the client, family, and yourself? Peritoneal dialysis. The peritoneum serves as a semi-permeable filtration membrane. Waste products, excessive fluids, and electrolytes are filtered through the peritoneum after the prescribed dwell time, and the outflow flows into the drainage bag. It could be continuous ambulatory peritoneal dialysis, or CAPD, which is an infusion of 4 2-liter exchanges. The dwell time is 4 to 8 hours, so 4 times a day. It does require 7 days a week, but clients can continue normal activities during CAPD. Or peritoneal dialysis may be automated. They use a cycling machine for dialysate inflow, dwell, and outflow according to preset times and volumes. So an example would be 30-minute exchanges, 10, 10, and 10 for inflow, dwell, outflow for 8 to 10 hours. And I know I see that a lot in the hospital done at night. PD indications for older adults are patients who need dialysis but they're unable to tolerate anticoagulation. They maybe have difficulty with vascular access, have chronic infections, or unstable, or have those chronic diseases like diabetes, heart failure, severe hypertension. Pre-peritoneal dialysis nursing care does include daily weights, labs, vital signs, assessing the client's ability to self-perform peritoneal dialysis and follow the sterile technique. Educate them and let them know fullness can be felt while the dialysate is indwelling. And discomfort is initially with dialysate infusion is expected. It's not a complication. This does lessen by warming the dialysate, either by using heating pad or warming chamber. You do not want to warm the dialysate using the microwave. So do not warm with the microwave. Intraperitoneal dialysis nursing care includes monitoring vital signs, assessing that inflow volume compared to their outflow volume. You want to monitor the color and clarity of the dialysate. It should be clear or light yellow. Clear and light yellow. Monitor for any signs and symptoms of infection if they have fever, bloody, cloudy, or frothy outflow. Assess for potential complications such as exit site drainage leaking or exit site leaking. Maintain surgical asepsis of the catheter insertion site when accessing and disconnecting catheter. Box 60.12 on page 1486 gives you more detail about peritoneal dialysis catheter care, such as making sure you and the patient are masked, using proper hand hygiene, sterile gloves, changing those gloves, assessing for infection, and using aseptic technique for site care and dressing changes. You do want to keep the drainage bag lower than the abdomen so that it will flow out, and reposition the client if inflow or outflow are inadequate. And then post-peritoneal dialysis, you would want to get another weight, vital signs, and labs, and then assess support with home peritoneal dialysis. Do they have someone at home that can assist them with this? Potential complications include peritonitis. So PD can allow bacteria into the peritoneum. So cloudy outflow is the earliest sign. You can refer to that action alert, page 1486. Fever, abdominal pain or tenderness, rigid abdomen, fatigue, malaise, nausea and vomiting, all signs and symptoms of peritonitis. Kind of refer back to what you learned in 1940. So what would your CBC look like if you have peritonitis? Poor dialysate inflow or outflow can be due to constipation, obstruction of tubing, or client positioning. And bleeding. So when the PD catheter is first inserted, outflow will be blood tinged, but this should be clear outflow within 1 to 2 weeks. If it's persistent or new blood tinged outflow, that could indicate infection. Other changes of color of outflow, if it's brown, it could indicate bowel perforation. If it's the same color as the urine plus the same glucose level, it could be bladder perforation. Or if it's cloudy or opaque, it could be infection. And then, of course, dialysate leakage is also a potential complication. For nursing care, for peritonitis, we want to report all abnormalities to the provider We want to prevent progression of infection and peritonitis. So we're going to anticipate or recommend a specimen of the outflow for culture insensitivity. For poor dialysate inflow or outflow, we're going to reposition the client. So turning them to the opposite side, maintain neutral body alignment, reduce abdominal pressure with supine low Fowler's position. Check the tubing or kinks for closed clamps. Teach the client to eat a high fiber diet and use stool softeners so that it wouldn't be due to constipation, and ensure the drainage bag is lower than the abdomen. For dialysate leakage, look at the exit site from the PD catheter. It should be clean, dry, and without pain or inflammation. And then when first starting PD, they usually start with small volumes. It takes the client about 1 to 2 weeks to tolerate the full 2-liter exchange without any leakage.